So we're going to go ahead and start the chapter on joints. And this will be the last section of material that you'll have before the next lecture exam. So also be careful when you do internet searches for joints, because as I found, I was looking for joint meme. And I forgot that the rest of the world, most of the rest of the world, has a very different interpretation for the word joint. So that's why I put that up here. So yeah, when I searched for joint memes, I got all kinds of interesting things. So, but obviously we are going to be talking about these joints, the joints that are basically between two bones, holding those bones together, but also allowing movement. And we call this an articulation. So again, anytime that two bones are, moving but held together, that's going to be called an articulation. So that's kind of our fancy anatomy word. We can't just say joints, or maybe rightfully so, because again, the rest of the world has a different interpretation for that word. So we use the term articulations. And so again, we can have the point of contact can be between two bones. But again, you'll see this isn't as common. This will be in things like your fibrous joints, like your sutures. Or it can be between cartilage and bone. So like you see here, you've got that articular hyaline cartilage, remember, on many of the surfaces of the bones that are involved in a joint or articulation. Excuse my dog in the background there. And you also will have a point of contact. It's a very special joint that we'll talk about called a gomphosis between the teeth and bone of the mandible and maxilla. So when we talk about joints, of course, the main function of the joints is to give us that skeletal mobility. But at the same time, to hold the skeleton together, right? So we want these bones to be able to move and allow us the movements that we have. But at the same time, we want to hold our skeleton together, okay? So that's the main function of joints, to hold the skeleton together, but at the same time, allowing mobility. And the study of joints has a very special term called arthrology. And then if you've ever heard the term kinesiology, just for your own benefit, kinesiology is actually the study of movement. So oftentimes, obviously, that involves joints. So classification of joints. So oftentimes we will classify the joint using its structural classification. So that just means basically what is the joint made up of, okay? So we're going to talk about fibrous joints, again, are going to be made up of this fibrous, dense connective tissue. Cartilaginous joints are going to be made up of cartilage, you guessed it. And then synovial joints are going to be made up of this special kind of capsule and then synovial fluid on the inside. So those are going to be our three main types of structural classification. So again, the structural classification is a little more clear-cut, so it's more commonly used. But oftentimes, we will also tell you its functional classification as well. And so these are the three terms. I know we in anatomy can't just say very simply immovable, slightly movable, or freely movable. You know that we have to have special terms for them. And so you can think, again, arthrosis is, again, think of that as joint, okay? So arthrosis that's why it ends with that term. And so a synarthrosis is going to be an immovable joint, okay? So that's going to be one that doesn't move. It doesn't have movement at that joint. So we'll talk about that with the sutures of the skulls and things like that. Then we have slightly movable joints that we call amphiarthrotic, or amphiarthrosis is the term. Again, amphiarthrotic is kind of the adjective form of it. So amphiarthrosis, it means just slightly movable, and this will be things like your vertebra, okay, that can move a little bit, but not not quite as much as like your hip joint, which is going to be totally freely movable, and that we call diarthrotic, okay, or diarthrosis, again, diarthrotic being the kind of adjective form of it. And so that means it's just freely movable. Most of your joints, the majority of your joints in your body are going to be diarthrotic, okay? Because most of our joints, as you're going to find, are synovial joints, and synovial joints are going to be diarthrotic. So that just means they're freely movable, okay? So we have quite a bit of movement at those joints. I mean, you can see that as you move your fingers and you move your arms, right? At their joints, there's a lot of movement at that joint, more so than your vertebra. Okay, so let's go back and we're going to talk about each of these different structural classifications, okay? So first we're going to talk about fibrous joints. That was our first one, remember? Okay? And so fibrous joints, again, are just going to be these joints that are held together really closely by this dense fibrous connective tissue. And mainly, right, it's going to be your dense regular connective tissue, okay? And there's going to be no joint cavity here because, again, it's just fibrous connective tissue holding those two bones together. Most are synarthrotic. Again, that means immovable, synarthrotic. Or, again, amphiarthrotic, meaning just slightly movable. And again, this depends on the length of the connective tissue fibers, which you're going to see in my examples here. So there are three types of these fibrous joints, okay? So you're going to have sutures is one, okay? So that's one type of fibrous joint. Syndesmoses is another type of fibrous joint. And then three gomphoses is the third type of fibrous joint. And again, they're all considered fibrous joints because they're all bones that are held together purely by this dense fibrous connective tissue, okay? So again, keep that in mind as you're going through this. Sutures, syndesmoses, gomphoses are held together by dense fibrous connective tissue, okay? Not cartilage, not some synovial membrane, okay? With ligaments running through it. So again, that's for your sutures, your syndesmoses. And this is an example. We're going to talk about this. These are example of your sutures here in the skull. Syndesmosis we'll talk about between things like your radius and your ulnar, or your tibia and your fibula, with these interosseous membranes. And then we'll talk about your gomphosis here. So I just like this diagram because it kind of shows you an example of each. And you can see when we talk about things like your sutures are going to be these really short joints with this, short, dense, fibrous connective tissue. So again, doesn't allow for movement. So those are going to be more immovable, where here you'll get a little bit of movement because these joints are going to be a little bit longer with your syndesmosis. So anyway, I'm going to go ahead and talk about each of these, but I just kind of wanted to introduce that here. So fibrous joint number one. So I remind you that these are all fibrous joints. Fibrous joint number one, sutures, okay? And again, these are going to be these joints, these really tight joints that are going to interlock kind of the puzzle pieces, right, of the skull, the bones of the skull, okay? So this is going to form things like our sagittal suture and our coronal suture here, our sagittal suture, okay? Our lambdoidal suture, things like that, okay? And again, these are synarthrotic, okay? So synarthrotic means, again, not movable, okay? So these don't move, and we don't want them to move a lot, right? Because we want this to be a good protective covering for our brain. So, but we need these because it will allow for growth of the brain, especially again in children. And so as those bones grow a little bit again, and as the brain grows, it allows for a little bit of stretch, right? As that brain develops. Now in middle age, okay, when we're fully developed, those sutures are just going to ossify and fuse. And then we'll be left with this kind of complete skull, right? That's all joined into one unit to be able to protect the brain, okay? So again, eventually these sutures will fuse into like your coronal frontal suture here and your sagittal sutures and so on. Okay, so fibrous joint number 2 is your syndesmosis, okay? And so syndesmosis is going to be where you're going to have bones, 2 bones that are connected by ligaments. But again, the difference between this and a suture is going to be that they're going to be a little bit longer, and that you're going to have a little bit more space in between the bones versus the sutures. And again, sutures are going to be primarily in the skull. Syndesmoses are going to be in other bones, primarily a lot of your long bones of the body. So these are going to be amphiarthrotic, so different than sutures, right? Amphiarthrotic, again, just means it's going to allow a little bit of movement. And how much movement it allows kind of depends on how long the fibers are. So short fibers are going to allow just a little bit of movement. Longer fibers are going to allow a little bit more movement, okay? So for example, the tibiofibular joint down here is going to have pretty short fibers. So this is at the distal end here down by your ankle. And then this is just a ligament that's holding together, helping to hold together the tibia and the fibula at that distal end, okay? And so these short fibers are going to allow for a little less movement than things like your interosseous membrane between your radius and your ulna, which again, as you if you right now twist your wrist kind of back and forth so that you have your palm up and then palm down, palm up, palm down, you can feel that those bones need to be, without moving, if you hold your elbow in the same place and then just twist your wrist, you're going to feel that those bones need to be able to move. And so again, you can see that this interosseous membrane is important because it holds, again, those bones together. It holds your radius and ulna together, but still allows you to be able to flip your hand up from what we call supination to pronation, which you're going to learn in just a little bit here. So to allow you to do that rotation. Same here, we have a big interosseous membrane between the fibula and the tibia. And again, that also is going to help to hold together the tibia and fibula, but allow some movement as well. So again, this interosseous membrane as well as this tibiofibular ligament, both of those are examples of syndesmoses. Okay? So those are all some examples of syndesmoses. Fibrous joint number 3 is called a gomphosis, just kind of a funny name, right? Gomphosis, which is kind of, funny name for kind of a funny joint. Again, this is a special joint. It's your peg and socket joint, meaning your peg is your tooth in the socket, right? In that alveolar socket or alveolar process. So again, the only examples of this are your teeth and your alveolar sockets. And this is synarthrotic as well, like your sutures. You can picture that because, again, you don't want your teeth like moving around in there. You'd be losing your teeth right and left, right? That only happens as the periodontal ligament loosens up and deteriorates when kids, right, are losing their baby teeth. So again, the actual ligament that's going to hold the tooth into that alveolar socket in either the mandible or the maxilla bone is going to be the periodontal ligaments, okay? So for those of you that are dental hygiene, here you go. That's your periodontal ligament. Pretty important there. Holds that tooth and socket. So here you can see again, here's your tooth, the peg, and then here again is your alveolar socket, which is going to be in either, your mandible on the lower jaw or your maxilla on the upper jaw. And then you can see that periodontal ligament kind of tight, holding that tooth tight in that socket. Okay, so those were your 3 types of fibrous joints. Again, sutures, I like this diagram, your sutures, your syndesmoses, and your gomphoses, okay? Yeah, so this is a good one to kind of remember your fibrous joints. All examples of your fibrous joints. And then cartilaginous joints, okay, are going to be your second big structural classification. So we had all of those. We just talked about fibrous joints. Now we're going to move on to cartilaginous joints, okay? And so unlike fibrous joints that were all made of that dense connective tissue, here now the bones are going to be held together by cartilage, hence the name cartilaginous joints, right? beautiful when it works out like that. So sometimes, again, some of them will be held by fibrocartilage, some of them will be held by hyaline cartilage, and we'll talk about which is which in just a minute. And so, but these guys lack a synovial cavity. So again, only synovial joints are going to have a synovial cavity. It allows little to no movement, okay? And the two types are going to be synchondroses and symphysis. You guys have probably heard the pubic symphysis, so you kind of know some of this. But you're probably not super familiar with synchondroses. But again, think of chondra, okay? Think of chondra as cartilage, okay? Syn, immovable. So this is a cartilaginous immovable joint, synchondrosis, okay? So hopefully that will kind of help you out with remembering those terms. So the connective tissue in synchondrosis, I highlighted it here, is hyaline cartilage. So you want to, like, again, kind of memorization here. Think synchondrosis, hyaline cartilage, okay? These are going to be immovable joints, and your really good examples of this are going to be your epiphyseal plates, okay? When the epiphyseal plates are still open, then these are called, again, synchondroses, because you have a joint there, right? That's held together by cartilage. So, and you know there's hyaline cartilage there because, again, we talked about this in the zones of growth and all that. So, again, there's your epiphyseal plate. And a great example of synchondrosis, okay? Again, immovable, right? You don't want that to move. That would be really bad. If like the, head of your femur was like moving around. Not good, right? So, okay, and then your other example here is going to be between the ribs and the sternum, this costal cartilage. So all of this costal cartilage here is going to be a synchondrosis, okay? So all of this is another great example of that. Okay, so a symphysis is going to be fibrocartilage. So I tried to do these in different colors for you. I could have done better, but here's yellow, synchondrosis, hyaline cartilage. So symphysis, orange here, fibrocartilage, okay? So again, you just kind of have to do a little memorization here. And so that fibrocartilage is going to be kind of a tougher cartilage. But it is going to allow for a little bit of movement. So it's amphiarthrotic, okay? And so it's a tough cartilage, but again, it'll have a little bit of squish to it. So this is a perfect example of a symphysis would be a intervertebral disc, okay? So all of your intervertebral discs are made of fibrocartilage, so they're a symphysis joint, okay? And then also here, the pubic symphysis is another perfect example of this. Now, this pubic symphysis, again, is amphiarthrotic. It just allows slight movement. Although when you are pregnant, okay, you do release a hormone called relaxin. And that relaxin hormone actually loosens this joint, this fibrocartilage a little bit, and allows a little extra mobility. That just allows, again, for the birth canal to kind of open up a little bit more, this pelvic inlet, again, to allow for the birth of the baby. So those are your two examples of symphysis. But as you're going to see, the majority of your joints are not going to be fibrous joints. They're not going to be these cartilaginous joints. The majority of them in the body are going to be synovial joints. The vast majority of the joints in your body are going to be synovial joints. And this is probably what you think of when you think of a joint. So these bones are going to be filled by this fluid-filled joint cavity that you see here. And these all, this is nice and easy for you to remember, are going to be diarthrotic. All are going to be freely movable. They might not be freely movable in all different directions, but they are going to be freely movable in some direction, okay? And this is going to include, again, almost all of your limb joints, okay? So, and then you can see here that you're going to find that the synovial joints are going to have different features to them, but they'll have this synovial membrane that will actually secrete the synovial fluids. Okay, and then that synovial fluid will fill that joint cavity. So again, that synovial fluid is going to be kind of a thick but slippery fluid that will allow kind of for the movement of those two bones quite easily within that synovial cavity, and provides, again, kind of a buffer, so it decreases friction. And then, of course, the bones are also themselves going to have some articular cartilage. So synovial joints are going to be in joints where you need to move them a lot. So for example, your finger, you're constantly moving your finger, right? So you need to be able to, one, have that be freely movable. So you need this nice slippery fluid. That synovial joint provides that nice slippery fluid, okay, that allows that free movement. But also we need to protect those bones because there's a lot of movement going on. We're constantly moving that joint. So that's why the majority of our joints are going to be synovial joints. So we're going to talk about the special 6 features that these joints have. I already kind of talked about some of them, but we'll go ahead and go through them. So synovial joints are going to have these 6 special features. One, we already talked about, they're going to have articular cartilage on the ends of the bone. Okay, so here's that articular cartilage to protect the ends of the bone that are involved with that joint. Now remember that that articular cartilage is made of hyaline cartilage. And again, this prevents the kind of crushing of the bone ends, okay? Then number 2, we need a synovial joint cavity. So we need to have this fluid-filled space that's kind of unique to our synovial joints. So this cavity right here that will be filled with synovial fluid. We need to have an articular joint capsule. So we have this kind of two layers to this joint capsule. We have this external fibrous layer, and then we have this internal layer, which isn't depicted here. But it's more importantly is that you know that it has this inner synovial membrane. So again, it has an outer membrane just to really hold things together, but there's this inner synovial membrane that is going to be this loose connective tissue that makes synovial fluid. So that's why this is important here. So that synovial membrane is what's going to secrete the synovial fluid. Okay. So here you can see just an example of this. Again, you've got that they show you the fibrous outer layer, and then here's your synovial membrane. That synovial membrane, again, is going to line this joint cavity and make that synovial fluid. And then here you have your articular cartilage here on the surface of the bones. So those are the main structures that are going to make up your, and now, of course, the joint cavity is going to contain synovial fluid. So those are going to be the main structures that are going to make up your synovial joints. So again, we talked about the synovial fluid. It has to be viscous, like somewhat, again, it can't be just like water, somewhat like thick and cushiony, but also it has to be slippery, okay? And this is actually produced from a filtrate of your plasma. So you have blood vessels that are innervating that synovial fluid, and then some of that plasma is going to move across into that synovial cavity. From this membrane. And so it will, again, release a filtrate of plasma and then this hyaluronic acid. That's kind of the like slippery stuff in your synovial fluid. So the hyaluronic acid, I do want you to know that because that's, again, kind of unique, again, to your synovial fluid. And it does, again, provide this nice kind of slippery lubricant surface. Or liquid, I should say, liquid in there. So again, the synovial fluid is going to lubricate, but it's also going to nourish the articular cartilage because again, there's no kind of blood vessels going directly to the cartilage there. And cartilage has very little vascularization. So the synovial fluid will actually help to provide some of the nourishment for that articular cartilage, as well as, again, of course, its main function to lubricate the surfaces there. And then it does also contain some phagocytic cells to remove some of the microbes, if there were microbes that got in there, and debris as well in the joint as you have injuries and things like that. However, there are obviously cases where people have gotten infections inside their joints. These are definitely more difficult to treat because, again, you now have this, infection inside this synovial cavity. And so they are a little bit more difficult to treat. Different types of reinforcing ligaments. So we have ligaments that will reinforce these synovial joints because, again, there's a lot of movement there. So we also need to make sure that we still hold those bones together. So we have the capsular ligaments, which is just the thickened outer part of right outside the synovial membrane, right? And then we're going to have the extracapsular ligaments, which are going to be just outside the capsule. So these are going to be outside of the joint capsule. Things like your fibular and tibial collateral ligaments. Do I have some of those here? But anyway, they're going to be the joints that are outside here, like here. You can see this is a different ligament, but here you can see or tendons as well. Here's a tendon of the quadriceps, and then you'll have ligaments as well that will hold again like you'll have your tibial and your fibular collateral ligaments there. So again, you're going to have these joints. I thought I had a great image of it, but I don't. But you'll have these, and you'll see these in lab. You'll have these ligaments that are outside the capsule holding those bones together. And then you can also have intracapsular ligaments, which are, again, gonna lie kind of inside. Technically, kind of, you can think of them as lying inside the cavity, but they're actually lined with synovial membrane. So they're covered by synovial membrane. So they're not actually like inside the synovial fluid. So they're just kind of going across what would be the inside of the synovial cavity. So kind of, I'll show you this in just a minute, but you can think of, honestly, you can just think of them as they're gonna, again, be going you can think of them as inside that cavity or inside what would be that synovial cavity, even though they're just being picky and saying that here, as some of these ligaments, like your ACL, your anterior cruciate ligament, and your PCL, your posterior cruciate ligament, that are going to actually go across here, are technically not like going right through. They're not like poking through the synovial joint cavity. It's basically like the synovial joint cavity kind of like lines around them. So again, they're just being picky, but I'm not gonna be that picky for you. You can just say it lies inside of that synovial cavity. And so again, these are going to be things like your ACL and your PCL, your ACL, your anterior cruciate ligament, which you're going to see in lab, in your PCL, your posterior cruciate ligaments. And that provides a little extra stability in some of these, joints that are really used a lot and need that. And so like your knee joint, this is very important for your knee joint. And then lastly, our number 6 is that we have nerves and blood vessels that are innervating the synovial joints. So then the good part is that we have nerves that detect pain there. And you know this if you've ever torn your ACL ligament, or again, if you've ever had some swelling inside that synovial cavity. Okay, you know that you can detect pain, and this is a good thing because this helps us kind of monitor what's happening in the joint, right? So the other thing is that we have nerves that kind of monitor the joint position, right? And send that information back to the brain, and also tell us again if the joint's being stretched or overstretched, things like that. And then, of course, we have capillary beds that are going to the synovial membrane, and they're going to supply the filtrate for the synovial fluid. Okay, so other general structures that we'll see in some synovial joints, not all of them. Some of them have fat pads. So here you can see here's a fatty pad here in the knee. And this is usually for cushioning. So sometimes it's cushioning between a fibrous layer of the capsule and the synovial membrane or the bone. So again, a lot of times we just have these fat pads in areas where we need a little extra cushioning. And then also articular discs, which you're going to see again in lab, like menisci. So here you can see again in your knee joints here, you're going to have the lateral meniscus and the medial meniscus. And this is really going to help to kind of hold the two surfaces of the knee joint so they don't slip out so much. So this is, again, a kind of thick layer of fiber cartilage, and it really is there to help improve the fit of the bone, and it stabilize the joint. So if you picture here, again, these are those condylar surfaces here of the femur. And so, you know, when those condylar surfaces, again, are going to be interacting with the condylar surfaces on the tibia, you want to make sure that, you know, it doesn't get pushed out this way or pushed out that way, right? So we add this kind of like cup. It almost acts like a little bit like a cup to help kind of hold that bone in place. And then it will also help to reduce some wear and tear because it is extra cartilage here on that joint as well. But again, the meniscus really stabilizes that joint. And any of you that have torn a meniscus know how important it is to that joint. I know someone that actually tore their meniscus and it folded back underneath it. And so his knee joint was really unstable until he had it repaired. Bursa. So bursa and tendon sheaths are important because they're kind of these extra things that we have. Again, not all of your joints will have these, but these are kind of these extra features to really help in areas where you might have a lot of friction, extra friction. So these are going to be bags of synovial fluid, or again, we'll talk about tendon sheets are going to kind of be these sheaths. They're going to be these kind of bags that are folded over around certain structures, but their main function again is for lubrication. So extra lubrication, kind of acting like a ball bearing. And so again, they're not strictly part of synovial joints. They're just kind of closely associated, and they do again have synovial fluid inside them. But they're kind of their own entity, okay? So they're in different areas than right, you know, between two bones. So they're usually meant to, like, for bursa, for example, to reduce friction, like where ligaments, muscles, skin, tendons, or bones are going to rub together. So it's not usually like, again, two bones like you see in your synovial membrane. So I'll show you some examples of this. Actually, let me show you bursas here. So for example, here, you know, you have this is a perfect example of some of these bursa and the why you would really need these. So here you've got the patella here, right? And so you really want, again, a little extra protection because you're constantly, think about how much you are moving your knee and how often, and you can see here is going to be one of the quadricep muscles, and here is going to be that ligament that holds the patella, that runs, basically the patella runs right through it, and then it attaches to that tibial tuberosity via the patellar tendon. We'll talk about this again in lab, but you can see that there would be a lot of friction if this bursa wasn't here between these two surfaces, right? All day long. And that would really wear down this bone. You could think of it like if this was a rope, right? On like even a smooth rock surface, eventually that rope would get frayed, okay? So, that's why we have these bursa. Okay, usually they're not just to protect bone, but also to protect ligaments and tendons from basically wearing down, wear and tear, and fraying, right? Like you can think of them like that. So again, that's why we're gonna have these nice bursa. Bursa are basically these like little packets, little like nice round packets of synovial fluid. Okay, and so you can see we've got bursa here in the shoulder joint as well. A lot of these joints that are heavily used, we're going to have bursa in them to help protect them. Again, from that constant friction. Now, we also have tendon sheaths. And the only difference between a tendon sheath and a bursa is the structure. Tendon sheaths are going to be these more elongated, long bursa that kind of like wrap around tendons. So they're going to kind of like surround the tendons themselves. So they're just different in shape, basically. That's it. And so here, I think there's an example. Oh, here's a nice tendon sheath. You can see where it's like going to wrap around the tendon here. In this case, the tendon of the biceps brachii. Okay. So that just shows you. And again, it really helps to protect that tendon. So you can think of it, it's not, getting that wear and tear and fraying. Okay, so some factors that influence the stability of synovial joints. So obviously, again, the shape of that articular surface is going to be really important. So, if you have a shallow surface, so for example, like, the more shallow ball and socket joint that you have for your shoulder, right? That depression, the glenoid cavity is much more shallow than like your hip joint. The acetabulum is a much deeper surface. So because of that, your shoulder joint is going to be less stable. So it's actually more likely to undergo, luxation, which is where you pull, again, that basically dislocate that joint. And so again, the shape of the articular surface is going to be one factor. Also, of course, ligaments, the number of ligaments that you have in the location is going to affect how strong that joint is. So the more ligaments you have, the stronger the joint's going to be. And then muscle tone as well. And this is actually going to be the most important. The most important because this one is really the factor that's going to affect that like reinforcing of those joints. So muscle tone keeps the tendons taut, right? Because again, tendons are what connect your muscle to bone, are going to keep those taut as they cross the joints. And that really is what holds that joint together. Now, for example, this is extremely important in reinforcing the shoulder and the knee joints, okay, as well as the arches of the foot, but you can picture that. Now, if you know people that are prone, and I actually have a son with this issue, that he has a connective tissue disorder, and so his tendons are a little bit loosey-goosey. And so because his tendons are a little bit loosey-goosey, it actually makes him more susceptible to dislocating his shoulder and his knee. So he has to be kind of careful with that. So a lot of people that, again, are more prone, or sometimes this happens if you've had like multiple injuries. If you've dislocated your shoulder many times, you've kind of maybe torn and stretched that tendon out a little bit. So again, that can also kind of make you more susceptible to some injuries there. Okay, so I'm going to go ahead and stop here, and then I will start the next lecture with movements that are allowed by the synovial joint.